Understanding chronic obstructive pulmonary disease, COPD. Chronic obstructive pulmonary disease, or COPD, is a lung disease that makes it difficult to breathe. COPD is a long-term disease that often gets worse over time and is characterized by inflammation and severe limitation of airflow in and out of the lungs. COPD is an umbrella term used to describe a group of breathing conditions, the most common being chronic bronchitis and emphysema. Many people living with COPD may have both emphysema and chronic bronchitis. A few people have both asthma and COPD. Cigarette smoking is the leading cause of COPD. Long-term exposure to secondhand smoke or irritants such as air pollution, dust, or workplace fumes, and biomass exposure such as wood smoke can also contribute to COPD. An uncommon genetic disorder called alpha-1 antitrypsin deficiency is sometimes associated with COPD. Although respiratory infections such as influenza and pneumonia do not cause COPD, they can make people with COPD very sick. Therefore, it is very important to keep these vaccinations up to date. At first, COPD may cause no symptoms or only mild symptoms. As the disease progresses, common symptoms include shortness of breath, wheezing, and chest tightness, especially with exercise, and an ongoing cough, often with a lot of mucus. As COPD symptoms worsen, breathing requires much more energy, and it can get harder to exercise or do routine activities like getting dressed or climbing stairs. This may lead to fatigue, weight loss, and muscle loss. People with COPD can experience a variety of symptoms. Different stages of COPD range from mild to moderate to severe. In normal functioning lungs, when air is inhaled, it travels down the windpipe and into the airways, or bronchial tubes of the lungs. Inside the lungs, the airways branch out into smaller and smaller tubes called bronchioles that are rich in blood supply. At the end of these tubes are billions of tiny air sacs, called alveoli. Normally, the walls of the airways and air sacs are elastic and flexible in nature. Inhaling causes each air sac to fill with air. Exhaling causes each air sac to deflate. Efficient uptake of air into the lungs provides oxygen to the blood, which is then carried to all parts of the body. In COPD, however, the airways become thick and inflamed, and they produce more mucus than usual. This mucus can clog the airways and makes it hard to breathe. In COPD, the walls of the air sacs in the lungs are damaged and lose their elastic quality. The air sacs get floppy, broken, and lose their shape. As the air spaces get larger, air gets trapped, and there are fewer air sacs to supply oxygen to the blood. Because air is trapped in these air sacs, it is difficult for lungs with COPD to deflate like normal lungs. This trapped air makes it harder to get fresh air into the lungs and makes breathing more difficult. COPD is the third leading cause of death in the United States and affects more than 13.5 million Americans. It is predominantly diagnosed in middle-aged individuals older than 40 years and is present in both women and men. Although COPD is more common in men, more women die from this disease each year than men. The rate of COPD continues to increase worldwide due to smoking and worsening air pollution. While there is no cure for COPD, you can take steps to feel better, stay more active, and slow disease progression. COPD can be managed by consulting early with your healthcare provider, seeking diagnosis and intervention therapies, and adopting lifestyle changes that include quitting smoking, pulmonary rehabilitation, healthy eating and exercise, and maintaining a positive outlook.
clinician who has 14 chronic diseases to manage in a 7-minute period of time because he's got 35 patients that I got to see, that can help us in terms of predicting when there's going to be benefit of a particular therapy. And there's a large and controversial, Peter, evolving literature regarding the role that eosinophils, circulating eosinophils, have. There have been 5 papers in the last week and a half published on this with contradictory results. And so I don't know the exact answer to this, whether eosinophils identify a person that has more of Frank's allergic asthmatic component, whether that's the biological process, or whether it's the patient's host response to deal with viral infections with eosinophils are supposed to be aiding us. Exactly why that's occurring, it's unclear to me, but there is a hint amongst multiple studies that eosinophils are likely going to be predictive. In whom and at what threshold, I still think remains unclear. What do you guys think?
So Fernando gave, for the first time in this discussion, mentioned an important term, and that's personalized, and the other word for that is precision medicine and targeting. And Jim talks about the Wisdom study, which was a non-inferiority study, and when you withdrew steroids, it didn't meet the non-inferiority criteria, therefore we say steroids didn't benefit. But the reality is about 5% more exacerbations, not statistically significant or not inferior, occurred. So the question is, in that 5% or whatever, those people suffered, okay? So the point is getting markers, biomarkers, to identify the subgroups of patients, whether they're clinical biomarkers or blood eosinophils, because if we use the old-fashioned style where we have 1,000 patients in a trial and the average goes up here, but if you look at the individuals, some of them are dropping, a bunch of them are going up, a bunch of them are staying the same, and you start looking more precisely at that group, you're going to dissect patients who benefited and didn't benefit. And can we predict those up front is the key question. And eosinophils is currently the bullseye, and is it going to work or not, and we need to dissect it a little further.
So let me just, and I want Frank to comment on this. So the COPD Foundation, working with the FDA, set up a biomarkers consortium. The concept being biomarkers, as most people know, serve as endpoints for clinical trials. So they're really important because if you do a drug study and you aim for a biomarker that the FDA doesn't recognize, the study may be fine, but you may not get your drug approved. So the foundation has run this. Frank is now the medical director, and eosinophils is one of the ones we hope to look at.
We've already submitted a letter to the FDA that eosinophils are going to be coming there.
One of the things with the eosinophils in the studies, we lose our power when we start looking at 500-600 cells. There's just never enough numbers in the study. However, if you do have enough, the risk of an exacerbation when you start getting up to 400 and 500 cells becomes 50%. So you can do quantitative analysis like Dr. Suisa did around that concept and actually come up with a quantitative estimate of what the risks are of these various drugs, which that's coming out in chest. It's online now, but I think we all should look forward to that.
All right, so let me see if I can synthesize very, very briefly, put a bullet point. And it may not be fair, but I seem to hear, okay, we can go without the inhaled corticosteroids, but in a subset where the eosinophils may be higher than we would like, then steroids might make sense.
Yeah, I think that you come back to the question that you asked, Jim. So many people are on triples already. I can't tell you that's wrong. I mean, for some people it's probably right. I will tell you that I do what Frank does. That if they've had a history of pneumonias, if they've got osteoporosis, if they've got other concerns, I'd be more likely to try to downgrade them off of the inhaled steroid to a LAMA-LABA. On the other hand, if someone comes in to me, they're doing fine, they don't have those issues, I don't know, I'm probably going to leave them alone. But perhaps more importantly, as a startup point, if they're very mild, maybe you could use a LAMA alone. But beyond that, I'm with Frank. I start a llama lava, unless maybe this eosinophil thing will, or the asthma concept would change it.
And as an example of the complexity, Byron, if they have a little osteoporosis and 7% eosinophils, are you less likely to taper them?
Probably less likely and more likely to treat their osteoporosis.
So there's not absolutes here, but we take we're beginning to take these into account. If they had 0%, but they've had a bunch of flare-ups and they've previously been tapered, are you going to taper that steroid? No, because it's not an absolute.
What are the eosinophils doing? Are they reacting to some etiologic agent, or are they actually the primary cause of the symptoms of this?
We can say that in an exacerbation, usually it's primarily neutrophils and macrophages, and then the eosinophils come in later. That's why we use oral corticosteroids or systemic corticosteroids in the treatment of an acute exacerbation. But clearly some patients have asthma COPD overlap, and they express this Th2 inflammation. We can measure it by looking at eosinophils and things like that. So I think it's a little bit of everything, and just the cascade, the inflammatory cascade has a lot of different components.
The one thing I think we can all agree on is that systemic steroids have only one role in this disease. 5 to 7, maybe 10, but 5 to 10 days during an acute exacerbation. So all these people who come into us on 5, 10, 20 milligrams of prednisone for years, that has no role in this disease.
Now, what about if exacerbations are continuing despite an inhaled regimen? What else can you add to decrease the exacerbation?
Two drugs that are being that have been used widely and that have some evidence behind them and are part of a PCORI study would be Daliresp, the phosphodiesterase 4 inhibitor, and azithromycin, the common antibiotic used daily, macrolides. And they're actually being compared in a study, but most physicians use either the side effect profile of the phosphodiesterase 4 inhibitors a little bit more pronounced with GI side effects, but they're both approved drugs. Not approved for that indication with the macrolide, but widely used. So that's drug 4 usually. Certainly before we go to 5, which would be something like oral steroids. And in development now with these asthmatic phenotype, a lot of people are looking at biologics that have been used in asthma in the field of COPD, but I don't find that as terribly attractive to me.
Then there are a couple of nebulized versions of phosphodiesterase inhibitors that may be coming fairly soon that don't have the GI side effects that might be worthwhile.
So I have a comment that relates to this question, the future of this question, and the last question. So there was a biological experiment just presented at the European Respiratory Meetings and put online in the New England Journal 2 years ago, and that tested a drug, Mepolizumab, which is an IL-5 modulator that specifically decreases eosinophil count. And this drug only worked in patients with elevated eosinophil count. It abrogated eosinophil levels within 4 weeks to almost 0, and the higher the eosinophil count up front, the more likely we are to reduce exacerbations with this drug. So that answers a biological question. A better answer to your question is the eosinophil the bear or the bear track? And that suggests that at least in part the eosinophil is the bear. And the second thing is that could be Jim's 5th drug after it goes to the FDA, and Jim does his usual presentation there to convince them it's a worthwhile drug.
recent studies, there are correlation and association between eosinophilic inflammation and fibrosis in the airways. And there is another important correlation between the severity of the disease and the eosinophilic inflammation. The gold standard treatment in COPD and in asthma is sometimes inhaled corticosteroids. The problem is that at the moment there are not consistent data to demonstrate the effect of inhaled corticosteroid in COPD. Many years ago, we had just one marker. It was the inflammation derived by bronchial biopsies, but the technique is very invasive. Now we have other biomarkers. First of all, the eosinophilic or neutrophilic inflammation in asthma and COPD with the use of induced sputum. And you can find these cells in the expectoration of the patient with asthma and COPD, or nitric oxide, a measurement of nitric oxide, and more recently, the use of blood biomarkers are very useful, seems to be very useful because are very non-invasive and very simple to have by the patients. I think that the eosinophilic inflammation depends by the time of the disease, because generally the airway inflammation in COPD is a neutrophilic inflammation. But sometimes, for instance, during the exacerbation, we have the possibility to find eosinophilic inflammation, almost in the 30% of patients. And this is a very interesting data because the inflammation could determine could target the therapy for COPD patients. The best ways to perform longitudinal studies on the use of eosinophilic inflammation in induced sputum or in the blood to evaluate the disease and to standardize, to stratify the disease, and to select the right treatment, to a sort of target treatment.
For the New England Journal of Medicine. Chronic obstructive pulmonary disease, commonly known as COPD, is characterized by progressive airflow obstruction, cough, sputum production, and dyspnea. Acute exacerbations leading to treatment with antibiotics, glucocorticoids, or hospitalization are common. Up to 40% of patients with COPD have an eosinophilic phenotype, with blood eosinophil counts of 2% or more. The these patients have an increased risk of COPD exacerbations compared to patients without blood eosinophils. Could such patients benefit from decreasing eosinophils by treatment with Mepolizumab, a monoclonal antibody that blocks interleukin-5? Two randomized placebo-controlled double-blind multinational studies